All right, thank you so much for the opportunity to present today. I actually grew up in New York City, so it's great to be back home. Although when I lived here, I always try to avoid Times Square as much as possible. Now I'm stuck here for 3 days, so it's all good.
Wow. Short.
I didn't mean to be ungrateful, but today I'll be talking about utilizing a PMEG to fix a TBE that was complicated by type 1 endoleak. So the patient is a 67-year-old male who was transferred from outside hospital. He has a history of type B dissection long time ago, over 10 years ago, from zone 3 to 10. And that's complicated by aneurysmal degeneration of the descending thoracic aorta. When he got to us, it measured to 6.7 centimeters, and about 5 years ago, per the records, it was only 4.5. His other medical issues are as listed. And looking at the scan that's playing right now in that first panel, you can see the aneurysmal degeneration pretty proximally, and the true lumen is fairly compressed. But all the visceral vessels do come off of the true lumen, and there is some small distal fenestrations. So the initial repair that we performed actually was left common carotid to subclavian transposition to debranch that carotid, and then we performed a zone 2 TVAR with the TBE device, 37 millimeter approximately, and to achieve about 15 to 18 millimeter of proximal seal. The proximal aorta measured about 32 millimeters. Then we extended the TVAR graft distally to the celiac using a CTAC device. Unfortunately, on postoperative CT, it did demonstrate a type 1A endoleak, as demonstrated on the middle panel, the top pictures. There was pretty early filling out the aneurysmal sac, as well as that carotid stump, which was ligated during the initial debranching. So what are our options at this time? We consider, a patient can undergo open chest and completely debranch the innominate and land a more possible TVAR. However, that would require open chest surgery, which the patient would likely not tolerate given all his comorbidities. We could also do a carotid bypass, but that would require us to kind of go into that redo neck surgical space, also deal with the retroesophageal tunnel, and his neck was short and stubby, so it also was not ideal. So to deal with this problem, we actually decided to perform a PMAG by modifying a 42 to 38 millimeter alpha device. We fashioned two retrograde inner branches within the graft using 9 millimeter Viabonds. We reinforced the fenestrations using gooseneck wire, and we constrained it with chromic gut sutures in a way that they minimize the space around those retrograde inner branches, so that when we do go in and cannulate it, we'll have an easier time. And the last thing we did is we reduced the nose cone size, because as we know, some of the Cook nose cones are pretty big. That way we can get the device as proximal as we can. We performed this by obtaining bilateral growing access and left radial access. We put up the device and deployed the device with the constraints still intact. Then we proceeded to cannulate the subclavian branch into the previous TBE, and then we brought out the wire through the left radial access for through and through wire access. And then we cannulated the innominate branch, and the cannulation was hard to see on angio, so we did confirm that with IVUS that the cannulation is good. Then we released the constraint and with the mop balloon, and the branches were further stented by bridging into the vessels. We then completed the procedure with a stabilized technique using a 42 millimeter Zenith dissection stent from Cook. And the postoperative CT and completion angiogram is shown on that right side. And it showed the resolution of the 1A endoleak, and the true lumen on the follow-up scan is expanded. So there had been already a lot of discussion today regarding off-the-shelf devices versus a PMEC, and there may be a shift towards using more off-the-shelf devices due to medical legal concerns. But I think there will always be a role for PMECs, just because they allow total customization based on the patient's unique anatomies, or if they had previous devices that you can salvage. I think the off-the-shelf devices are more like rigid set of rules, but if you understand the rules enough, you can also always bend them a little bit to your advantage. But PMECs do have some shortcomings. They're limited by the devices that are modifiable, and then each modification can make the device exponentially a little more complex to deploy, especially in the arch where the flow and everything's anatomy is a little more dynamic. And there's no long-term data regarding PMEC outcomes in the arch, so we'll have to see. Thank you so much.